Well, I'd like to welcome everyone again to the first part of the 5-part webinar series focused on value-based care for the FQHC. It's real exciting to have the opportunity to help, I guess, talk about this very, very important topic. Again, my name is James Pat. I'm the Chairman and CEO of Insight Health Systems. We're a healthcare innovation company, and we're real excited to be working with Ohio Association of Community Health Centers, as well as our sponsors, United Healthcare Group and Cardinal Health, on this webinar series. Obviously, value-based care and patient-centered care coordination is the hot topic right now. As a country, we're going through a major transformation from this fragmented care pay-for-service model to a coordinated care pay-for-value model. And whether you're ready or not, it's here. And a lot of very, very exciting things are happening to continue to push the needle from fragmented care to coordinated care, from pay-for-volume to pay-for-value. And again, the purpose of this webinar series is really to talk about some of the key points that are going to impact everyone on this call. Obviously, there's change that's associated with this, and change is good, except obviously we want to talk about it. We want to build a platform that allows you to ask questions and learn from each other. So this is truly an educational series, and we're very, very excited, again, to be working with our sponsors on this. As I mentioned, this is the first webinar that's part of a 5-part webinar series. Every week, as listed, you'll see what the topics are. This first session today will be focused on quality measurement and reporting. We're very, very excited to have 2 great speakers on this topic. First, Dr. Lynn Hawley. Dr. Lynn Hawley joined Family Health in 2010. She received her training as a physical therapist from The Ohio State University and her medical degree from Toledo University, my hometown. And she completed her residency at Wright State University School of Medicine. She's dual board certified in both pediatrics and internal medicine. Dr. Hawley is a board member of the Wayne Hospital Foundation, medical director of Grace Resurrection Community Center, and the director of quality and risk management at Family Health. Dr. Hawley enjoys being a physician and being involved in community activities. And she has 2 children, 3 stepchildren, and a continuous growing number of grandchildren, and resides in Greenville area. So welcome, Dr. Hawley. Also joining Dr. Hawley is Charlene Wright. And Charlene joined Family Health in 2010. She completed her training in radiography from Reed Healthcare in 2004, and is currently an honors student at Mercy College of Ohio, pursuing further education in quality management, healthcare administration, and healthcare informatics. Charlene oversees the day-to-day quality improvement efforts and assists in regulatory monitoring changes for Family Health. She also oversees OSHA program, sits on various facility and community teams, including community patient partnership and risk. And she lives in Greenville area with her husband and 3 children. So Dr. Hawley and Charlene, thank you again for your time in presenting to the group. And I'm going to hand over the microphone to you. Let me make sure that both of you are unmuted.
All right. Thank you all for inviting us to speak on quality improvement, management, and reporting. The topics we have put together today will be addressing quality improvement in a rapidly changing regulatory environment. These changes are impacting quality metrics as we transition from fee-for-service to value-based care. We will be looking at the PCMH model and how it applies to population health management. We will also touch on the reporting analytics and what issues we have within our practice. Next slide, please.
According to the National Association of Community Health Centers, as healthcare changes from fee-for-service to value-based care at a rapid rate, dedicated health information technology and quality staff will be required to keep up with the regulatory changes. Health information and analytic positions are projected to grow by 25% by 2022, according to the U.S. Bureau of Labor Statistics. This is another indicator that health information and data collection are not going away. And as a result of the Affordable Care Act, patient outcomes are being publicly reported to promote transparency and to encourage patients to engage in their healthcare decisions. Cleveland Clinic is a leading example of transparency and has already published 14 outcome books, which report performance, managing conditions from cancer to cardiac disease. And the vision of value-based care is higher quality of care with safer evidence-based care at the lowest possible cost.
This is a very, very busy screen, and not there to overwhelm you, although it is overwhelming, to show the intricacies where it comes to how we're going to do value-based care. The Institute of Medicine established a roundtable on value and science-driven healthcare that focused on value, transparency, and continuous improvement. They put together evidence-based medicine and continuous learning with collaborative, informed, shared decisions to improve patient outcomes. You can look at the lower level. They'll talk about data analytics, information technology, and bring it upward. One other thing that's kind of near and dear to my heart as a physician, though, in all of this value-based care, I'm questioning where is the art in the art of medicine. This is another little graph on value-based care in more pictorial form. We need to start learning and understanding the transition from fee-to-service to managing care across the continuum. We need to stop looking at the patient's problem as the problem and look at the patient as a whole. This PCMH model is just a very good, great beginning to bring in care coordination, but you can't stop there. You must consider the patient and its hypertension across your clinic, your county, your state, and your nation. If you look at the slide, it does a really nice job of bringing in all of it. We are so used to just working in our little silos. You have your outpatient, your inpatient, home health care companies, but we need to take it from the very beginning and all the way through, and that's where we are going with value-based care. It doesn't just stop with taking care of one physical condition.
How can we be successful in value-based care related to a patient-centered medical home? A study in the New England Journal of Medicine by Michael Porter discussed a strategy for healthcare reform. The first step is through internal monitoring of quality metrics. Data that is monitored will drive the results. We already know that results are being publicly reported through various agencies, such as OAC and CMS websites. This data will be used to essentially grade a provider or organization's quality of care. The second step is that the data must be measured over a full cycle and not separately. We are used to operating in silos, and we need to have more interoperability. The third step is measuring health outcomes rather than process measures. The 2010 HEDIS measures, out of the 78 measures, all but 5 are process measures, and none show true outcomes. The quality data that we have been collecting is a good start. However, we need to further look into the projected outcomes to effectively improve our patient care. And the fourth step is having knowledgeable staff that is assigned specifically to quality improvement and analytics. There needs to be a continuous education opportunities for all staffing and quality improvement efforts due to the rapid regulatory changes and to promote buy-in from the entire organization. And the final step is data collection and reporting for population health management. We have learned in our practice that you cannot just hand out a numbered-based report card. The data needs to be presented in a visual format that is quick to digest and provide educational feedback on the results. Data that is monitored will drive the results.
The patient-centered medical home has been in the process for a long time, and a lot of our federally qualified healthcare facilities do have patient-centered medical homes. In our facility, we have a just new PCMH in its processes. We have all the proper pieces that you could ask for. We have excellent nurse practitioners, PAs with physicians, behavioral health with both psychologists, psychiatrists, dental and newly dental residents, lab, radiology, pharmacy, with community outreach and disease management. We're currently working hard on our disease management with our chronic care nurses, but what we're finding is we still need improved communication among all the areas. It's good to have some meetings, but at this point, a lot of our devices don't communicate. We need better transparency. We've also decided we need to be more creative and go outside of the box on traditional care. We're looking at using one of our pharmacists for our transition of care, and we'll discuss our transition of care project later, asking to see if we can have some home health visits with some of the nurse practitioners and physicians. We already have group visits with our diabetic nutrition classes, but we're looking at cooking classes. We're looking at getting our patients involved with walking with possible group visits with physicians. One aspect we've worked really hard on is our preventative care flow sheet. We're working hard to identify our high-risk patients. There's a lot of material out there that helps you identify. We've come together with our county and looked at what we feel our risk stratification is. And we'll show you an example of this in a minute. We've identified our population so it can be managed and tracked. We need to think much longer. We need to gather statistics over a continuum of time, and that's how you can prove your value-based care. We have community involvement currently with education, health management, and data collection. Again, the data collection is still our weakest point. We have diabetic classes combined with the weight management specialist. We're working at getting exercise facilities such as a walking track even in our area of our local Greenville facility. We currently now have an adult daycare center in the area with stress management classes that are given by our behavioral health specialists at Family Health. This is an example of our high-risk flow sheet, and I won't bore you with all of it, but as you can see, it's your standard kind of high-risk flow. We use our case manager to use the flow sheets involving both preventative diabetes and chronic conditions for the gathering of our statistical data, but also our management of our chronic care patients.
This slide gives an example, or gives a definition of quality from the perspective of HRSA and the Institute of Medicine. Quality care is evidence-based and effective patient-centered. I like HRSA's description toward the bottom, using a system approach to continuously improve clinical, operational, and financial domains. Quality improvement is about integrating all departments for the betterment of the organization and for the patient. The Institute of Medicine's definition is a little more straightforward. The National Association of Community Health Centers has resources on the steps to quality management. The foundation of a good quality program is establishing a quality team that incorporates all departments for comprehensive care. And continuously educating staff will promote better understanding and buy-in. In the event you're just starting, quality measurement can be overwhelming. And choose metrics that are applicable and most important to your practice. And FQHCs, we need to look at more the grant measures for UDS reporting and PCMH metrics. Meaningful use measures were our second step due to incentive money. Our next step was the HEDIS measures. We met with several insurance companies regarding how they collect the data and eventually added a staff position specific for insurance chart auditing. This recent position has allowed us to start collecting additional data as well as receive additional incentive monies from insurance companies. The OAC crosswalk demonstrates the alignment of measures across various reporting bodies. All of the masses of data collection need to have ongoing monitoring efforts, reporting including visual dashboards, and we are still working on the visual aspects for our program. It's very dependent on the capability of your EHR system. Essentially, the last step in using process improvement framework, PDSA cycles, Pareto's, most of us are used to dashboards. Dashboards are not as effective as explaining the process. The process looks overwhelming at first, but when you break it down, it's a little easier to digest. Visual presentations are more effective. We also have chosen to highlight 1 or 2 areas a month to review during provider meetings just to help with understanding and improve processes. And again, metrics that are monitored will drive the improvement process. We started with establishing a quality improvement team. Ideally, the quality improvement team is to have every department represented. A monthly physician report cards were handed out in a numbered dashboard format, but they were not explained. Education on flow sheets was done poorly, and yet this is where our system collects the data. And there was a lot of a lack of understanding on everyone's part. So we went back to the basics with dissecting where we went wrong. We started with educating our team on quality improvement process framework, educating providers on the measures. We selected 1 to 2 measures a month that the providers from the provider's dashboard to review, and we went back to paper at check-in with a preventative screening questionnaire that is checked by nurses and physicians. Collecting the data on paper at check-in helps stimulate the process of the updated preventative care flow sheet on the chart.
We certainly learned a few things the hard way. As Charlene stated, our biggest problem was the lack of education. We've learned that education from even the smallest things is the key. There was a great lack of understanding, and I think lack of understanding created a small area of distrust. We made this mistake with our physicians as well. We've learned that sometimes meaningful use does not mean quality. That'll be up to you to decide, but what we learned is as we're trying to get our physicians to do this click and this click, which seems meaningless, they weren't paying attention to the actual quality measures and quality indicators that we wanted them to pay attention to. And then we learned that not everyone believes quality is important. You do your job and you leave, and we tried to get a more buy-in at the most basic of level. One very important thing is that quality does not come without cost, especially when it comes to your EHR functionality. It's everything. Getting the data is everything if you want to prove what you are doing. Data in does not mean data out, and this is what we've learned. We've also learned that proper healthcare analytics appears to be the key. Analytics have to do with how we make the data accessible for use, how we use the data, how we measure the work, how we prioritize improvement opportunities, and how we monitor improvement efforts over time. Currently, our EHR does not handle analytics well. Quite honestly, it barely handles our metrics, let alone our analytics. Hence, we have to use crystal reports. Well, this has gone into the birth of all the analytic companies. There are some facilities that have reviewed grants to help with the cost. I currently know of a federally qualified clinic in Tennessee that actually got the grant, and they absolutely love using an analytic company in order to generate their data and feel like it's taken their quality measures as well as their processes to a higher level. We currently have an MBA in our company who's helping us, but he states that in order to properly put in the data and get out the data, it's going to take him a year on some of these processes. We just don't have the EHR system that allows us to do this. Showing your data will cost money, and we do realize that. We all need to understand that at the end of the day, from Medicaid, Medicare, and private insurances, your quality demonstrated will derive from your analytics. If you can't show it, it will not be shown. I believe this will include the type of grants that you get and affect your reimbursement rate. Does your head hurt yet? Because mine certainly does, and it does frequently. And we've learned to do a lot of this in baby steps. Population health management. And life's beautiful word that's showing that analytics are an important role in managing your PCMH on a small scale and population health on a large scale. Population health management identifies the population's risk stratification, monitoring, and tracking to determine your compliance and outcomes. It includes actual health outcomes over a period of time, tracking patterns of health factors, developing processes and interventions to improve population outcomes. In an ideal clinical sample, you would be able to decide which measure you like to do. One of the big hot topics right now is the colon cancer screening. So you would be able to hit a click of a button in your EHR and determine in this past year who is due for their colon cancer screening. From that, you would be able to send out a mass portal message about obtaining your screening. You could then reevaluate where you are 3 months later, who has and has not received the screening. From this, you could go to level 2, follow up on the ones and contact the patients and remeasure. This is a small example of population management at a metric level, but now you need to gather the statistics on how many were positive, how many were referred, how many were diagnosed with colon cancer at stage 1, 2, 3, 4. Ideally, you would keep statistics such as these mortality statistics, refusal, type of test refused, why the test is refused, and you could do statistics both short and long term on how to improve your own screening process. Then you'd be able to look at your statistics at your county level, your state level, and look at your long-term changes in morbidity and mortality. Currently, we do a metric, and that's what we're looking at, a simple metric. How many providers have this metric? But now you need to apply this at a much higher level with population care and analytic studies. Money, money, money. Currently, for most of us, federally qualified facilities receive level bundled payments. So how will value-based care affect these payments? How will they be adjusted? What about commercial insurance? We have incentive payments with Medicaid, Medicare Advantage. Commercial insurances are incentivizing physicians for metrics and outcomes. For commercial insurance, we added a preventative flow sheet, and we're working hard to work with insurance companies to push the data, then have a reactive audit. I don't know how many of you have commercial insurance, but the auditors just simply walk in, they ask to see charts, and they leave. We finally looked at each other and thought, what are they gathering, and how are they gathering it? So we have a new position we created at Family Health to help tweak this process. So when an auditor comes in the door, we sit with them. We ask them what they're gathering, why they're gathering it, where they're gathering it from. And we streamline them toward our preventative care flow sheets, which is what most of them are right now. From this, we're going to gather proper evidence-based data in order to respond to their audits. We did have an email conversation with Randy Runyon regarding value-based care. He's having conversations with other states that are already in negotiations. We feel that Medicare and Medicaid will be jumping on this because population health measurements and outcomes make sense to reduce costs long-term as you improve your quality.
Yearly, UDS and meaningful use reports are submitted, and the UDS report is available publicly to evaluate FQHC standing. Currently in our system, reporting is a blend of EHR reports and CRISPR reports that we have written. We have begun to review these standings and utilize the data to educate providers on chart documentation. And with this new internal position, specifically to work with chart data auditing and documentation in conjunction with the HEDIS insurance auditors. We have been able to identify areas of deficiency and education opportunities. However, we are not yet connecting the data for long-term use. Accurate data reporting will play an important part in the future of value-based care, and we foresee metrics being utilized in negotiations and bundle care value-based payments. Insurance companies may also come back with, if you're not a quality clinic or physician, then a reduction in reimbursement rates may occur, and it is no longer good enough to say you can do it, but you need to demonstrate it and with data and analytics. This slide goes through and demonstrates the OAC. They have developed a clinical quality measures crosswalk to show the alignment of measures across the various agencies. This is a great resource with measure descriptions, and I would recommend that if your quality personnel reach out to Ashley Ballard, who's the Director of Clinical Quality at OAC, to connect with the Ohio FQHC's quality listserv and for this crosswalk tool. And then also at the end of the presentation is a slide featuring quality resource websites that are specific to FQHCs and have been beneficial in our understanding on quality measurement. We as FQHCs need to start thinking in broader terms in regards to long-term outcomes. We have concentrated so hard on the metrics that we haven't measured the outcomes. Granted, we may see them and are proud of our efforts, but we have not measured them. We need to be proactive in developing PCMH models with population health management to be able to demonstrate our true value. Physicians need to be part of this process of evidence-based care, and physicians are becoming tired and they're overwhelmed due to the information overload with just one more click. Physician involvement will help to gain quality framework understanding and to promote buy-in.
We thought we'd give an example of how we started in Dark County with community involvement. We have a team that was developed, actually initiated by the hospital for transition of care. This team involves a group of physicians who are hospitalists, nurses, home care services. Basically, we had every nursing home representative, your home nursing service, your chronic care managers, and primary care. This was population health management on a baby scale. And what we decided that, and one example in this arena was our CHF protocols need to look the same. Every one of us had a CHF protocol, but none of them looked the same or spoke the same language, which we thought would be very confusing to the patient. So we decided to start getting a training program for the patient that looks similar. So when they transition from the hospital to the nursing home to the home health care to the chronic care in the clinic, it looks similar. We wanted to improve our communication amongst all of the above, improve our coordination of care, and improve the patient education. Again, it was a great idea, but there's no data collection because no system communicates with each other. The one people that did benefit was the hospital because of reduction in rates of readmission, but we've not been able to demonstrate anything good from the CHF point in the outpatient arena. Another example was a community project regarding substance use. We're certainly not alone in the state with our issues with heroin and what heroin problems have brought to our communities as far as issues regarding the overdose court system. We've had so many problems with crime, money, severe brain injuries with anoxia. We're putting some of these people in long-term care facilities. So we decided to do something about it. This involved community leaders, local police, sheriff's department, court system, our Dark County Health and Recovery Services, and family health, which involves physicians, pharmacists, and behavioral health specialists. And we got involved with the Vivitrol injections. It was a great idea, and quite honestly, even in its infancy, I can tell you we've had great success. One issue that we found, though, is we had one great area of success with one of our physicians who had a husband and wife, the wife's mother, the wife's sister, all on heroin. Through the Vivitrol injections and our behavioral health specialists, they all got clean, they got jobs. In those jobs, they got new insurance. The new insurance would not pay for their Vivitrol injections. So again, as a population management comes forward, we need to figure out a way to help each process along so that each system has problems solved. We were looking at measuring the long-term outcomes, including reduction of crime, which has to be more than just us, improved job outcomes, positive, contribute to society. It was a great example of doing something right, but we need to get the collection of the data because so many different levels of the organization is involved. Figure out who's collecting the data and analyze the data. There was a good article regarding the HRSA concerns with value-based care in relationship to the federally qualified health care facility. Just a second, technical difficulties here. And what we found was the value-based care is impacted by our EHR system. This puts a large financial burden onto our small clinics. Very important area is the HRSA's concern with your small clinics and your IT capabilities. Then you have difficulty getting your physicians to understand the measures and metrics, which becomes overwhelming, let alone all the procedural changes related to this. We found that clinicians work in the most information-intense industry in the world, yet they generally have not been taught the basics of analyzing and interpreting the volumes of data they encounter on a daily basis. It feels overwhelming to you to understand it as well. We are starting with baby steps, little tiny baby steps, and trying to plow forward. Next slide, please. We're going to conclude our conversation regarding progress. Progress, just make progress. It's okay to have setbacks and need to do overs. It's okay to draw a line in the sand and start over again and again. Just make sure you're moving the line forward. Move forward, take baby steps, but at least take steps that keep you from being stuck. Then change will come and it will be good. Practice these things, immerse yourself in them so that all may see your progress. We have learned the hard way in our little clinic in our time, and I made a point in one of our meetings that if you can walk in that meeting and you can get 25% done of what you intended to get done, then consider it a good day. The conclusion of this, we are available for any questions.
Dr. Holly and Charlene, thank you so much for taking the time and for providing such an excellent information to everyone. We really appreciate it and hope everyone found a lot of value out of this. Again, what we're going to do right now is we have a few minutes left for some questions and answers. So if anyone has some questions, if you can go ahead and chat that to me, and we'll go through as many of these as we can. So there's a few of them here, and I'll go ahead and ask them. And again, first question is, again, excellent presentation. Will the slides be made available? Yes, the slides and the recording of this will be made available. We'll send out a link to everybody, and they can download the slides at their leisure. One question here that came is, can you elaborate on the sources of the grants that you received for analytics?
We personally did not receive that grant. I talked to a clinic in Tennessee that's received the grant. We are currently actually starting our process of obtaining an analytic company. So we personally have not received the grant. There is gossip out there that these type of grants will become available as you saw, that HRSA article was quite good when it did discuss, the problems that we have in federally qualified clinics, and if you want us to be able to do that, then we need a little support. But currently, unfortunately, I do not know about the grant.
Okay, great. Another question is, it says they seem to have invested in a number of positions to support quality of care initiatives. Can you comment on the ROI on such hires? And if the ROI has not been realized, what are their expectations moving forward?
Can you redefine that question again? I'm sorry, you came in and out, so we had a hard time hearing it.
I think the gist of the question is the positions that you have to support your quality of care initiatives that required hiring new individuals to support those initiatives, and can you comment on the return on investment for those new hires?
The new position that we hired was a position. She works through with the chart audits, and as far as return of investment, with the HEDIS measures, there's so many incentive monies that are out there that are available that we were coming across. And by talking with the insurance companies individually and sitting down with some of their auditors, became aware of more incentive monies. For an example, I don't know if our finance director, how she might like this, but we just received a check for $7,500, and that was for basically about a month and a half or 2 months worth of work for this particular position, and it was strictly just to her dedication. So I foresee there's potential for a lot of good money there for incentive money.
Great, thank you. Okay, this question that came in says, what is the #1 thing that helps to get physicians to comply and participate in these efforts? They have a lot of part-time docs, and they're not very invested at this point.
2 things. One is education and appealing to their sense of IQ. Unfortunately, what I'm seeing with a lot of the literature on value-based care, they're treating physicians like they're kindergartners. They're putting up their little statistics, but they're not appealing to their IQs. They're not appealing in our clinic, and I mean this sincerely because I've worked with these people for 20 years. Most of them really do just want to do a good job. We have very few physicians in our facility that just come, do their work, and leave. If you appeal to them and with a process that actually helps them improve their quality of job, I've not gotten much care back on that. Treating physicians like kindergartners doesn't work. And I'm going to tell you that as a physician, it's insulting, and that's what's happening when we take all of this data and manufacturing processes and you apply it to a physician, because you are going to lose the art in the art of medicine if we're not careful with this. I actually sit them down, I explain the measures, numerators, denominators, and the why. When I stopped counting the meaningful use and started doing quality, that's when I had better buy-in.
Excellent. I think we have time for one last question. Question is, what steps do you take to ensure that all of your staff are aware of the issues and opportunities their analytics are uncovering, and that they take appropriate action on those opportunities and issues.
We have monthly meetings in our facility. We have provider meetings, we have staff meetings, and they're all on the same morning, the same day. We have a team of people from our quality team, and our quality team includes our head nurse coordinator, our IT specialist, our CEO. From the CEO down is involved in all of this, and the same information is being given in each of the meetings at the same exact time. It's not easy, and when we realized how important this was, that's when it started getting better.
Wonderful, wonderful. Dr. Holly and Charlene Wright, again, thank you so much for your time and for your presentation. I also, again, want to thank all the sponsors, the Association of Community Health Centers, Cardinal Health, and United Healthcare group for, again, helping to promote the webinar series. The second webinar series will be held on Tuesday, July 21st from 9 to 10. The topic will be payment reform models, and the speaker will be Randy Runyon, the CEO of the Association for Community Health Centers.